Okay, hello to everyone who's joined the webinar. A warm welcome to everyone, and I wanted to thank you for joining our Autism Care Pathway webinar, where we're very excited to share the new evidence on making a meaningful impact to autistic individuals and their families. And we're really excited that we had over 400 professionals and carers registering for this webinar. I realised there was a slight discrepancy in the start time, so this is just an opportunity to introduce yourselves on the chat function. So if you click on the chat at the bottom of your screen, and if you'd like to just write your name, your role, and that would be really helpful. Then everybody who's participating can see who's joining the webinar. And please feel free, we encourage participation. It would be very nice if there could be participation as we're speaking and as the presenters are presenting on that chat function. So firstly, if you have any practical difficulties or need any guidance or lose connection, please email our team on info@pacttraining.co.uk. Your mics should have already been muted, but if they're not, could you please click mute? And then if you are wanting to speak, particularly during the Q&A section, you can click unmute while you participate. There will be question and answers, so feel free to post your questions on the Q&A tab. That's a separate tab from the chat function, and you can post your questions on this tab as people are presenting. We do have a question and answer section at the end, and we'll try to answer some of those questions, but any questions we haven't answered, we will consider the responses and post them on the PACT website. A full recording of this webinar will be available on the PACT website. So the website is www.pacttraining.co.uk. And you will find further information on the website about PACT and contact email there as well if you want to contact us at any point. So I'm really delighted to hear Professor Jonathan Green presenting on the new scientific evidence that supports the development of an integrated autism provision from early identification and a care model from early infancy through to school support. Jonathan has pioneered forward-thinking and world-leading science dedicated to improving the effectiveness of autism care. And as we'll hear, this is included in the national guidelines to make it accessible to all children and families. It's an exciting time when we now have the benefit of a cumulative scientific evidence conducted over 20 years. And this includes new models of early identification, the potential efficiencies of digital technology, and a very family-focused intervention for parents and their children to promote sustained development. So the vision is to transform the science into practice and things that can be practically embedded within existing autism care services. And this vision is a shift from a reactive to proactive approach, where early support can make significant improvement in child developmental journeys. And what's striking about the science, and it's been a great privilege to be part of the scientific team and this accumulative evidence is that there are an infinite number of individual variables, and to have an umbrella term may not, accurately represent the range of individual variables. So what works for one person may not work for another. But what, importantly, these large-scale research trials and their follow-up studies give us is provide guidance on the process. And the process which has been illuminated is the importance of a balanced alignment of the interaction of the individual child profile with the adult, supporting adult. And the other important principle that comes to light is facilitating child agency by giving the child the power to be understood and to understand others. I'm also really delighted to hear two presentations from professionals who are working in the NHS and giving us examples of how they've embedded this new autism care pathway into their existing autism services. And this has been over building a service over several years. And I look forward to hearing about the feedback, their progress, and their vision for the future, how they would like to continue to progress this service. Because this gives examples of the science being weaved into existing practice. It's been proven to be feasible and proven to have added value. And so I'm really looking forward to hearing from our two presenters on the NHS delivery. So this is our agenda for the day. And I'm now going to hand over to Jonathan Green to give us the first presentation on early support for neurodivergent children and the new autism care pathway. So I'll hand over to Jonathan now. For those who've just joined us, please feel free to add your name and your role, where you work, on the chat function. It would be nice to know who's here and who's participating.
Okay, hi Catherine, hi everyone. Are we, we're starting a bit early for my presentation, Catherine, but you're happy to do that?
Yeah, that's fine, yeah.
So hi everyone, it is a real pleasure to be here with so many people who've been interested to join the webinar, and look forward to telling you about this, and particularly perhaps to have our some conversation together that and I hope that we can have good Q&A responses. I know it's not so easy on a webinar, but we'll do our best and see if we can create a bit of a to and fro dialogue around the kind of ideas that we're going to be presenting to you, discussing with you this morning. I'm going to kick off by outlining the principles of this pathway idea that we have developed and tested, and which grows out of the work, as Catherine said, that we've been doing over 20 years in developing quite a new kind of model of intervention support for autistic children and their families. And then I'm also going to present some of the early experiences that we've had in implementing this within the NHS in parts of Manchester, and that'll lead on to my colleagues talking about how they've developed this elsewhere in Greater Manchester and in the country. So I wrote about this back in 2019, and I think since I originally wrote this initial kind of position paper, as it were, the situation has amplified even more. But these were the challenges that I set out for us who work in clinical services within autism. And I think you who are joining us today will probably agree with this situation. I mean, if you don't, say so, but this seemed to me the situation that we find ourselves in. And as I say, since 2019, the situation has only, I think, amplified. One of the things is that our current clinical response to presentations of autistic children and young people and families who are concerned about their child's development has been basically too late, reactive to problems rather than anticipating them. Importantly, poorly evidenced. And I'll come back to the issue of evidence-based practice, which sort of informs this whole webinar, but really, and obviously I have this is my position on it, but evidence really does matter, and it does make the interventions that come out of it that are tested more efficient and more effective. But the current clinical response has been poorly evidenced, and it's also importantly episodic, by which I mean that there's this idea which really comes from other aspects of healthcare, that you have a problem, you do a time-limited intervention because you don't feel you've got enough resource to do anything longer term, and then you discharge the patient, as in the health service terms. There's an episode of care, and that's that. And those episodes happen too late in development. So the other challenge has been that diagnosis has been used as a gateway into care, and the diagnostic process is carefully done and importantly done, take time and specialist consideration, and that inevitably leads to escalating wait lists and a diagnostic bottleneck. And I think we all know about this, and there've been plenty of reports and national guidance documents, etc., documenting how this has ballooned, especially over the last few years. And then and that's been with the expanded awareness of neurodiversity and autism. And the extraordinary figure, which is around at the moment, is that at the current time, something like 80% of CAMHS referrals relate to neurodiversity of one kind or another and autism. I mean, this is extraordinary. So services are struggling with this. I think everyone, all of you on the call who are involved in services will agree with that. And we need an efficient way, an evidence way, and an effective way of managing this. So what I've proposed in this position paper was that we need to think of autism as developmental and enduring for a start off, and the support needs to reflect this. There's no point having episodic care in a condition that is an enduring state of being and state of development, which in itself doesn't always need care, but when it does, we've got to give the appropriate support. And I propose that we need to link detection and care so that we don't have people sitting on waiting lists, families sitting on waiting lists, worried about their children without an answer, sometimes for 1 or 2 years. without any support, just sitting on a wait list. And then we need more evidence kinds of care, particularly for interventions, therapeutic supports that are focused on family and have shown to have long-term developmental effects. And the importance of that is that if we're going to put our resources into doing something, we need to do something that's going to have a long-term and an evidence long-term effect. That is, you know, we've got finite resources in the health service. We have to use it most efficiently to things that are going to make a difference to long-term development and family functioning. And there are lots of kind of ways of organizing service models that we need to develop to deliver this through development. And one important principle when one looks at enduring healthcare kind of service models is this idea of self-management. And it is that the person who's experiencing the issue needs to have be empowered to understand and look after their own care. And I think this is well recognized now and important. And for us in the autism space in early childhood, this means empowering families to understand autism, to be able to empower to work with it effectively. And that's a key to the kind of intervention that we've developed. So why the other sort of big shift in this pathway model that I'm going to present to you is to go pre-diagnostically and what we call preemptively, sort of anticipating things in development rather than reactive to problems. And this is a big shift in mindset, which I know from experience, you know, really has to be advocated to both practitioners and service managers for why we should do this in a developmental sense. And my argument for this, and I hope that you'll see how this is worked out in practice, is it's more efficient to do this because we can link early detection to pre-diagnostic support and care. And I'm going to show you how we can do this. It's more effective if we do this because families are happier earlier. They're not sitting stewing on wait lists. They have more increased resilience, which I hope we can show you. And children have enhanced early development from the earliest times, and they're not sitting around waiting for developmental support. So early is really better in this way. But we need to show that with evidence. There's no point just stating it as an aspiration. We need to show how this can work efficiently. The other thing, which is, and you know, healthcare is not just about money, but money is important in the health system. And we have shown, and it's very important to show, that this kind of approach is actually cost effective. So we have, of the two interventions that I'm going to propose to you this morning, the I-BASIS and the PACT, we're going to talk about both. We have cost effectiveness studies, independent cost effectiveness studies on both of them. And, you know, these are really important results, so that this study in Australia of I-BASIS showed that if you invest every dollar you invest in this kind of early anticipatory support, is shown to save $3 by middle childhood in reduced service use. You know, that's an important advocacy argument for why we should shift our approach to be more preventative or proactive or whatever you want to say. And in the PACT intervention, we've also shown that the PACT is cost-effective into middle childhood in modeling across its use in Europe. So it actually works both at a sort of clinical level, as you'll see, but also at a cost level. So intrinsic to this pathway is the kind of support model that we're talking about here. So I'm just going to spend a little bit of time describing this. And it's family focused, and it's based on increasing family resilience through parent mediated intervention. That's the formal way of putting it. And we use a video feedback technique in order to do this most effectively in a way that you'll see. But the important idea of the model, as you'll see as we develop the slides, is that we don't work directly in this model with the child at all. So this is really a radical difference from the way that specialist professionals have worked in the past with autism. We're not working directly as professionals with the child, we're working with the family through the parent. And the wager of this is that by doing that, we instigate a cascade of effects within the naturalistic developmental process in the family, which actually benefits the child as it comes through. And that is a wager because, you know, it's not necessarily, it might be a nice idea, but it's not necessarily obvious that doing that would actually impact child development. And we've had to test and show that in the science we've done, as I'll suggest to you. So the idea is that we work with parents, that we introduce this cascade of effect between parent and child, and then the other bit of the wager is that the child will then make use of this change in the family and generalize that new learning out into the world beyond the family. And that is another big wager about how these effects could generalize. And these are important things we've tested in our studies. So it's this cascade effect that we're after, based on the idea that early interactions, communications between young children and their caregivers are so important for so many aspects of later development in terms of feelings, trust, relatedness, social motivation, mental health, well-being. We know that this is the case from many, many years of developmental science research in neurotypical development. And the key things about the interactions are about this idea of attunement and how the parent-child interaction sort of fits together and is responsive. The big challenging question is, how does this work when you have neurodivergent development? What happens to the transactions, the early transactions with caregivers, and what effects might that have on later development? And this leads us to think that our intervention supports should be with the parent to help them, empower them to optimize these early interactions, their understanding of the child and these early interactions, attunement, goodness of fit. It's important to emphasize that this is not a parental training. There is no assumption here or implication that there is anything wrong with the parenting. It is to acknowledge the situation that parenting a neurodivergent child for any parent has challenges, because the development and the communication can be difficult to make sense of for regular parents trying to do what we all do as parents intuitively. And our supports aim to help parents do this intuitively, to be the best parent they can be in the situation. And the wager is that we can help them do that, and that will then lead to positive outcomes downstream for the kid. So that's where our intervention is directed, at the parent, just because they're the people who are best going to be able to impact this social environment around the child. So just to give you an example of how the video feedback works, this is the sort of core technique that Catherine first sort of developed in her practice, which really been the core of the way that we've developed this kind of model. And what we basically do is take a videotape of a parent with a child in a naturalistic context with various, this is just one example, there are various sort of setups that we would use. And we take the video and then we play that video back with the therapist and the parent. So this will just give you the idea.
Stop. Oh, yes. Together. Push. Stop. Nathan, stop. Say Pico. Pico. Oh, where's it going? You found me. You're so clever. Clap hands.
So in the course of the work in both iBasis and PACT, that kind of video material is then played back between the therapist here and the parent who you've already seen in that videotape. And this is how it looks looking at that particular clip between them.
Yes, the one where he understands Nathan. Yeah, and he got quite excited when I stopped it. Yes, the first time you stopped it. Yeah. I think that's right at the very beginning, and that's something that's really quite interactive because I think he realised I did that, and it made the day more fun. Yeah. Well, let's watch that bit again. And see, just see what it is. Let's have a think about what made it interactive. What were you doing? What was he doing? What signals was he giving you? Yeah. So that that's what I need to read. This means he wants me to be in this bit. Yeah. Yeah. Let's see what he does. It's always quite dramatic.
So what I want to emphasize your attention to here is the style of this and how the parent is making their own discoveries within the video. It's not that the therapist is telling them what to do, how to be. This is not coaching, and this is not sort of psychoeducation. It's not modeling. It is really a mutual exploration of the tape so that the parent starts to understand their child and their interaction with their child in real time, watching the video of themselves. And we know, all of us who've done this kind of video feedback thing know how powerful this is for one to make one's own discovery. And it's the fact that the parent is immersing themselves and making their own discovery with the therapist's support and help, of course, that makes this such a powerful technique for adult learning, if we put it like that, and parent recognition and change. So important to say, particularly in the current context of the neurodiversity debates and environment that we're in, is that this kind of model is not about removing neurodiversity. I hope that you can see from this initial presentation that what we're doing here is actually quite the opposite, that we are attending to being interested in valuing neurodiversity. I'm trying to understand it, and by responding and making best understanding and responding to it, enhancing that neurodiverse development. It's not about saying we need to replace neurodiverse development with something else. It's about making the neurodiverse development the best it can be through this kind of social engagement, attention, recognition, and validation. In essence, it's validating neurodiversity. And that's, in principle, what you'll need to know, and what you'll want to know is how does that work in practice. So the two interventions which have the same basic principles behind them that we're going to show you, the iBasis is this early support that's designed for babies, initially infants, pre-diagnosis, who are showing early signs of an autistic trajectory. It's based on home-based delivery, manualized, it's neuroaffirmative, and it uses this video feedback kind of technique that you've seen, using 10 home-based sessions over about 5 months. So it's that sort of length of intervention. In terms of a lot of autism interventions, this is very low intensity. And already said, it's collaborative and strength-based, basically, and parents are asked to do these daily practice plans, building on the video feedback work with the therapist. And as the parents get into this, they're getting increasingly autonomous in how they deliver and how they integrate this work into family life. And that is such an important characteristic of this, because of course, if parents do that successfully, from the child's point of view, if you want to say this, they're getting 24/7 therapy because they're getting this adapted environment all the time. And that's what makes this kind of style of work, if it actually is effective in changing that, so powerful and so long-term in its effects through development, as you'll see. So we've done a whole series of clinical trials on this kind of approach. And the most extensive on this infancy support is this one in Australia, over 100 children followed up until 3, published a few years ago in JAMA Pediatrics, which is a big American journal, and showing clinical trial outcomes. The PACT intervention, as I say, conceptually related, in the way it's been formulated initially was clinic-based in its operation, and that's how we initially tested it. It can be used, however, at home and in education. We've done it in education as well. It can be delivered online, and particularly, of course, like so many during COVID, we generated the online capacity for this very successfully. And actually it works tremendously well online, as my colleagues will I'm sure tell you later. And this is slightly longer, so PACT, it varies how long we do it, but over between 6 and 12 months, around 12 sessions, that kind of time. And it can be applied. The way we've mainly done it is preschool, but it can be applied up to about 10 years of age. And it includes also the parent practice. And again, we've done a number of trials of this work with long-term follow-ups. And this Lancet paper in 2016, which many of you will be familiar with, presented our long-term follow-up into middle childhood from preschool support intervention. And that is the longest, and it remains the longest trial follow-up of any autism intervention. So what are the effects? I haven't got time to go into the detail of the science of these, but they're all available in the papers. What I want to emphasize here is the range of effects that we get downstream as the result of this kind of intervention. And this is the crucial evidence that allows us to be confident that we can promote this in a pathway that I'm going to describe to you. So initially, we do get changes in parent synchrony. This is our measure of how effective the video feedback's been in really allowing the parent to tune in to the kid and respond to them in a way that's appropriate from tuning in. And this synchrony is the first thing that we need to show that we've actually made that change for the parent. And that proves to be extremely effective. So in all the trials we've done, there's never been a trial where we haven't shown this, that the video feedback we use is extremely effective in helping parents of all kinds tune in this way. And it's important to emphasize of all kinds. So initially, when we started this, people thought, well, the sort of educated parents will, high-income parents will be able to get hold of this, and maybe not others, etc. Absolutely not true. We have shown that this works across social class, ethnicity, cultural difference, and also in parents. And of course, there are many parents in this context who are autistic or have autistic traits themselves. And we've shown it can work with all those groups. So this is really a universal kind of effect. Then we show that the children, as a result of this, increase their social motivation and their engagement with the parent. And that's the key shift that the child makes as a result of this therapeutic approach. And remember, we don't work directly with the child at all. So this is all the result of empowering the parent and changing this attunement. And as a result of that, the kid starts to get more socially motivated, more engaged, more active, more communicative. And we measure that objectively using sort of video coding. And we show that consistently. We've never not seen this effect. So, which is an extraordinary result in across all the different cohorts we've done this in and cultures. And then we also show that the children who do this in the dyad with their caregiver also generalize that out when they interact with others, strangers, in this case, in terms of the trials, in terms of researchers, who when we test the children in assessment settings, in terms of all sorts of aspects of their behavior, including autistic behaviors. And we show changes in these. So this becomes a generalized effect outside the family, which in itself is an extraordinary result, actually, and says a lot about the way development happens. We also show improvements in child language as reported by parents. But when we do structural language tests in the lab, which are much sort of less sensitive to change, actually, we don't see an effect. We show improvement in child social communication and adaptation in a broad sense, both in home and school, and family functioning. And in one of our studies, when we did this in school, we showed improvements in challenging behavior. So this is by the end of therapy. And then importantly, when in PACT, we did this long-term follow-up for 6 years into middle childhood. So this is 6 years after the end of therapy. We showed sustained effects. And this is a striking, pretty and robust and pretty extraordinary result. So that 6 years after the end of therapy, we were still seeing treatment intervention specific improvements in child social initiations in the dyad. They'd sustain that over all that time. Optimized autistic related kind of behaviors, family functioning improved, and teacher reports of their adaptation in school actually different if they'd had the preschool intervention than if they hadn't. So this is a long-term developmental effect. The parents show a sustained increase in their well-being, and we got an effect which didn't reach statistical significance, but it did look quite convincing in the data that children were less anxious, or a trend towards that. So these are broad-ranging effects on child outcomes done in sort of rigorous assessments within the clinical trials. And that gives us a lot of confidence that this kind of approach really is making a difference within intervention. But then we have a lot of qualitative reports back from families, and you'll hear a lot more of this later in the morning. And these are really striking too, because, you know, it is how the parents and the families feel about their child and about their own parenting that it really is hugely important in terms of the sustained effect of this kind of model. And what's consistent across the reports that we get from parents, and as I say, you'll hear a lot about this from my colleagues, is how this kind of approach builds relatedness. It builds a sense of connection between the parent and the child. And we all know as parents that, you know, that is the crucial core aspect of parenting, early relatedness, and feeling, good feeling, well-being in the family. And we get this consistently, that parents start to feel this as they start to get this attunement in the dyad. So that's the approach. Now I just want to give you a sense of how this can be incorporated into a pathway model that is applicable within our current health systems, and that's important. I mean, there's no point doing this unless it's pragmatically realistic within our health systems. And I wrote about this model with colleagues a few years ago in 2022, about how we could incorporate this kind of approach into an early care pathway. And this is the pathway. It really starts, the principle starts with early detection, a stepwise monitoring approach to pick up early neurodivergent autistic trajectories early on in development, so that we could then link that with a care straight away with care, so that we're not making an identification and then having people sit on wait lists. We're actually linking early identification and early care. And that, I think, is a key principle, which then leads to a sense of family support and all the early intervention, early developmental impacts that I've shown you from the trials. This is the early work in development that we're focusing on today, but the full pathway also includes a whole load of other long-term supports. So this we consider foundational. If we can get this family-focused, family empowerment resilience in place, that is going to be foundational for the later developmental care of the child. But that doesn't mean families and children are not going to need further supports as they go into school, as development proceeds, as they go into adolescence. And we all know that a lot of these children are vulnerable to co-occurring mental health problems, etc. And we need ongoing supports for them. So you need a mechanism to build on this foundational care into the longer term. We're not going to talk about that so much today, but it is part of the general model. It starts with this foundational care that we're talking about. It doesn't end with it. We need to continue the support of families in an efficient way, because and this isn't endless therapy. This is about being really efficient with how we target care only when it's needed. And it's on the assumption that if we've done this early work with families, they won't need so much. They'll be more resilient later on and won't need so much later support, but they will need some. So just in a little bit more detail, this early work is about tackling the diagnostic bottleneck. So we need a surveillance tool that's going to pick up early likelihood or concern around neurodivergence or early autism development. And what we have used is this instrument called the Social Attention and Communication Surveillance Instrument, or SACSR. And this is a key component of the pathway, which then needs to be linked in with this early care that I've already described in IBASIS or PACT. But just to focus on this surveillance bit for a moment, it's important that we have a surveillance instrument that works empirically, that is robust, easily usable, but also shows its value in not over-diagnosing or over-identifying, not under-identifying. In other words, it needs to have what we call specificity and sensitivity. And there's a lot of work that's gone on into this particular instrument, the SACSR, and it has, in my judgment, the best evidence for this in the world now, and that's why we want to use it. It was developed in Australia by Josie Barbaro from La Trobe in Melbourne. And there's lots of published work on this for those of you who are interested in the science. So this JAMA Paediatric article in 2022 was summarized a lot of this early work. And the important thing here is the sensitivity and specificity is really good. And it doesn't overdiagnose children who are actually neurotypically developing. And you'll probably be familiar with an instrument from America called the MCHAT that's been used for many years. And actually, there's independent work that suggests that, I mean, MCHAT's fine, but what we call the positive predictive validity, which is the sort of key metric that we use, is better with SACS than with MCHAT. And this is an independent study. It was published in this year, which suggested that. So we think the SACS is a good instrument to use. You'll hear from my colleagues about how it works in practice, and I'll give you a bit more information later, but it's simple. It's used by health visitors and community workers, checklist approach, but also observation. They need training in it, but it works okay. The important feature of the pathway at this point is that, as I've said, we link this SACS-R identification to therapy, which usually, it depends on the age of the child. If they're under 2, then it's into this I-basis. If over 2, then it can be into PACT, and PACT has been used in this way. What's important about this pragmatically is that when we do this linkage, so remember, this is pre-diagnosis. This is a surveillance instrument that we pick up likelihood. It's not diagnosis, it's a likelihood, and we put the care in at that point. Right? This is the radical bit of this. And the point about that is that the therapist gets to know the family over the period of 5 or 6 months or however longer as they do this support. And they are then in a great position, and they will pretty much know at the end of that time whether this child has a diagnosis or not, to be honest. And at the very least, they're in a good position to contribute to the triaging and formal assessment options that can then happen. And what we feel pragmatically is this is a way of streamlining what we call stepped assessment and diagnosis. So not every kid is pushed into a neurodevelopmental assessment pathway where they're sitting on a wait list for specialists to look at them. This is a much more nuanced, graded, proportionate approach where we actually deal with the assessment piece at the same time as we're dealing with the support piece. And those of you listening who haven't experienced this may have lots of questions in your mind about how this could possibly work in practice, and I'm going to come to that. But the idea is that this will enable us to do a much more nuanced, efficient, effective assessment diagnosis process. Doesn't mean we don't put diagnostic assessments in, but they don't need to be with everyone. And please, I think I'll power through to the end of the slides, but I'm sure there'll be questions here. Very happy to answer them at the end. So there's this stepwise monitoring, surveillance, assessment, linked care, early foundational support with the therapy, and then this long-term support, as I've said, which we're not going to talk about so much today, but we need. It doesn't mean we don't value it. We need these specific treatments for and supports for co-occurring conditions like anxiety, depression, ADHD, OCD, and these need to be part of the service provision, and they need to be properly designed for autistic people and delivered by appropriate specialists. So this is part of it, but it builds on this foundational care. So that's the elements of the pathway. We've done lots of work over this in the last few years. There are implementation projects now all over the UK, and you're going to hear about some of them in a minute. Also in Western Australia and also in South Australia now, they're putting this pathway in at a community level. And we've done a lot of work over more than a decade in South Asia, doing something very like this in an adapted form in India, Sri Lanka, and Nepal. And these things work cross-culturally, and that's important to know for our own multicultural society. So we hope this improves access to care.